Chris, turning to you, what do you think has been learned about prostate cancer intrinsic genomic subtypes, and really what is the prognostic significance? What's the use in the clinic, do you think?
Well, I think we all know that not all prostate cancers are the same. We all accept that there are distinct molecular subtypes, but I don't think there's yet any consensus as to how we should define those subtypes. So we look at our colleagues in breast cancer, for example, and they've got it all worked out. They have different subtypes, they have different treatments for each subtype, and we're not there yet. So I think at the moment it's not of any clinical utility. So the various subtypes that have been proposed certainly appear to be prognostic, but they're not in a position yet to guide management. And of course that's what we want.
And what about predicting response to radiation or to ADT? Do you think we've made any progress there?
Well, it depends what you mean by predicting.
Okay, predicting response, so predicting a better response than average. Or
Yes, well I think we know that certain genomic subtypes are likely to respond better to radiation than others, and certain are likely to respond better to ADT than others. But I would go back to saying that doesn't amount to a predictive biomarker, because even if you can predict that you're less likely to respond to ADT, you're not saying ADT is futile, so you're still going to use ADT regardless.
Yeah, absolutely.
And as a surgeon, I see in my corporation, I mean, there is an interest using these tests to say, okay, that's a bad prognostic signature for radiotherapy, so we should use surgery instead. I say, yes, okay, but then you look at surgery, they don't do much better. I mean, so at this time, we have like, I mean, all the question here, we have a lot of prognostic marker who make sense. If you're young, you're 49, you've got P10 loss, RB loss, AR loss, I mean, that we don't need to be very smart to know they're not going to do well. But when it comes to indicating whether we should omit ADT surgery, radiotherapy, and move to more sophisticated treatment, that's we don't have that information yet.
I think probably a very important point is that we probably don't need more prognostic biomarkers.
No.
We've got plenty of those, and the urgent need now is for more predictive biomarkers.
Yeah, and also when we design clinical trial, if you take, not everybody is very enthusiastic toward the radiation oncologist, and you have plenty of combination trial with, but unfortunately most of them are still shotgun experiment. And maybe it's not yet the time to stratify the patient based on the signature, but at least obtain tissue and blood to create these, because otherwise we're going to be left with exactly the same observation.
I think that's the really good point, is that we have to collect this data and collect this tissue.
And we need to get organized to get that tissue, because otherwise we're not going to help these men outside.
But I would like to postulate that I think in the very near future, in the next decade, we will be saying that certain patients should get surgery and not radiation, and vice versa, based on genomics. And I really believe that will come.